straight we go to save time, go to our discussion. I have invited also a colleague from WHO, Dr. Linda, who has been very crucial in moving to support smaller facilities around Kawempe division. We have divided different technical support to different divisions, and she's for Kawempe, so that where possible, she can come in and offer some additional input. Thank you, colleagues. So our discussion is centered today on Ebola IPC, and we will be getting an overview of Ebola as a disease, and then an overview of IPC, and then we go to the core issues that we see when we do a scorecard assessment. An analysis is done. We see that screening is an issue, the coverage is so low, as well as the isolation capacity, and the ability of the different healthcare facilities, the lower healthcare facilities, to signal the system, that is to signal the KCCA, so that a cascade of action, appropriate action is done whenever a case has been identified. We will also go through, of course, the environmental cleaning and waste management, very crucial, as well as looking through, therefore, the case definition. We have reviewed it quite a lot of times, and then so we get the latest case definition for a suspect case, and then we can be able to look through and discuss more on that. So just to start with, we are discussing a filovirus, that's Ebola virus disease, which was first actually made a diagnosis in 1976 near the Congo River, a river called Ebola. And from that time up to today, we have about 32 outbreaks occurring globally. And most of, actually all these outbreaks are within Africa. The reported Ebola cases outside Africa has been cases of healthcare workers who have worked in the outbreaks and they are going back to their country, then they get diagnosed. And so what is it therefore as a disease? So we are saying here is caused by Ebola virus. There are about 3 key species that Uganda has already surfaced, and we'll mention them as time goes. And therefore, we also know that it is a highly contagious infection disease with a invariably very high case fatality rate. So of the people who get Ebola disease, you find that about 60 to 90% can die. Citing the 2019 outbreak, where 4 out of 4 cases died, that was 100%. And of course, the current one, we are still in it. So at the end of it, the calculation will be made. So, and then we know that it's a febrile illness with a non-specific symptoms. And in the setting of Uganda or in the tropics, where quite a lot of febrile illnesses are there, it complicates the early identification of a case, because you find that cases are coming in, like you think they are malaria, or the patient itself themselves think that that's a malaria, and in that sense, therefore, they will be taking the usual trend of events that they do. They can seek care from a local traditional healer. They can buy drugs from pharmacies. So quite a range of action, and those are that's the main reason why we are discussing today, to see how to improve the early recognition and then appropriate cascade of action. So one would ask, therefore, how is Ebola transmitted? Where does it even come first from in the first place? So we know very well, we have been actually having already 7 outbreaks of Ebola in the country. And so each time it comes, we question ourselves, where has it come from? But just to summarize it up, we have what we call the spillover events. That is when a case of Ebola has been transferred. Actually, transmission has occurred from an animal into a human, the first human or the first individual, giving rise to the index case. So that in that transmission is what we are calling a spillover events. So these spillover events have been known to be the main reason for Ebola coming up. And of course, if one case is identified and confirmed, that becomes an outbreak. So when you see a lot has been documented about the natural host for the virus, where fruit bats have been identified as one of the key hosts, and from that we know the fruit bats can be able to interact with indirectly with other animals, the duikers, apes, through directly or indirectly through the fruits that they eat, because from the fruits they eat, some of them drop down, and then the infection can go into the apes, duikers, and that's how we can also eventually interact. So either we interact directly with the fruit bats by eating halfly eaten fruits, like a mango that has been halfly eaten by a fruit bat, a child has eaten it, or you can have fruit is eaten up by an ape or a duiker, then eventually we interact with those, giving rise to a spillover event, and then eventually a first case. But also we know that Uganda, Kenya, Uganda, Sudan, and DRC accounts for about 79% of the global outbreak of Ebola. It has occurred about 14 times in DRC, 3 times in South Sudan, and now 7 times in Uganda, and that accounts for a majority of the global outbreak. So the question is, therefore, if it occurs in DRC, is it likely to occur in to transmit, to be transported to Uganda? So again, that's the second mechanism, the importation of a case from one country to another through the porous border. We have about 900 kilometers porous border with DRC. So between the two countries, anything can happen, and that's one of the mechanisms. And of course, we have been discussing the third mechanism, where a case can come up way beyond the 42 days where an outbreak is declared over. And then the case can come up from among the people who have recovered. We talked about the virus living longer in the gonads. So again, that's the general principle. But overall, we have infections coming in from the natural hosts and reaching into the human population. And within the human population, that's now where majority of the cases will come up, where you find transmission will occur through all the body fluids that any body fluid that you can get contact with from an infected person. You have a case and has vomited, there is blood, there are some secretions. So all those, if you get contact with contaminated body fluids, you can be able to get the infection. And we know that comparably, the animal to human transmission is quite rare, as opposed to the secondary transmission that occurs between human to human. The last case of Ebola that was being diagnosed in this current outbreak was a mother-to-child transmission. The mother was negative, having recovered from Ebola, but later on she was pregnant, and there was a fresh stillbirth, and I think it was macerated, and a test was done and it was positive. So that was also a case of a mother-to-child transmission. Then how is the transmission? How is it Ebola transmitted among the different population? What is the key factor transmitting to aid this transmission among the key population? We know that healthcare workers actually are at the front line. Everyone who gets sick comes in to interface with the healthcare worker, be it at the small facility like the clinic, or even in a pharmacy. And so that's the reason why we are discussing here. Your interaction with the patient, if you don't put on appropriate PPE, you don't screen the patient, can amount to an infection. And this is a common occurrence for every outbreak, you find that healthcare workers at different levels are the first to get among the different population to get affected before the diagnosis is even made. So when you look at the 18 cases of healthcare workers infection that we have had, you find that majority of these actually occurred early in the infection when people were relaxed, they were not following the guidelines. But of course, we know also another key thing is the funeral rites, burial process in the communities plays a major role in the transmission, and we know that the corpses are actually highest. It is highly infectious, and so when you look at the community how they conduct burials, can easily lead to quite a lot of secondary transmission of Ebola within the community, and those two scenarios actually are the main reason for the secondary transmission occurring within the population. And we also understand that different communities can think different about this infection. Some of them may not believe the infection. Some of them think it's a myth, and from that, therefore, they will fail to adhere to whatever guideline is given and continue with these practices of burials, exhuming bodies, and that kind of event. So then the risk of Ebola, I've already said that the human-to-human transmission mode is the one that is most frequent, one a case has been identified, and it is uncommon for the spillover events. And Ebola also, we know that can live for quite some time on surfaces, and different number of days have been projected for different surfaces. I wouldn't want to go into them, but we know that a patient can be able to touch the tables, the chairs, the doors, and those kind of things. Or even when we manage the patient, we have the medical equipment that we have used on the patient, like thermometers, and even the body fluid spilling on the floor, the vomiters, the urine, those can contain quite, they contain the virus, and they can take some time on that surface. So that will call for an intervention, which we'll be discussing later on. So how is it transmitted from person to person? We have already discussed this, and we know that a person who gets infected has up to 21 days as the incubation period to show up symptoms. And when they show up symptoms, that person actually is infectious. And those without symptoms are actually not infectious. So that's one thing we should know. And the clinical presentation, we said they are quite a wide range and not clearly defined and can be confused with other infections. We're saying here that initial infections mimic many of the common infections, malaria particularly in our case here, where you find when you check in OPD, daily attendance in OPD, a number of cases of malaria that have been diagnosed on the RDT is quite high. And of course, with some other infections, differentials as well, including dysentery, typhoid. So when you look that confuses the clinical presentation and makes it difficult for us to probably screen effectively this patient and initiate the appropriate intervention. So we therefore can classify this presentation into wet symptoms, dry symptoms, whichever we want. And but the most important thing in this slide is to understand that the Ebola case that you have in front of you may be mistaken for a case of malaria and any other infection. And also we should know that while we always want to look for a bleeding patient, a patient with a bleeding from the nose, the eyes, ears, nose, and we are saying here that may not be presenting to you. Only 30% of the patients with Ebola may present with this, and they will not bleed from all the os that one can just have bleeding, PV bleeding or something like that. I think one of those early cases that eventually had to infect the health worker from Tanzania, the student from Tanzania, was a case of a PV bleeding. So you will not see all the bleeding from all the O's and for all the patients. So that's one thing to take note of. And so what are the signs and symptoms of Ebola? Again, one would wonder, would you want to wait for all the bleeding? Is it going to be the case for all the cases coming to you? We're saying here that the first stage of this infection, in the first stage, you find a patient is presenting with the unclear symptoms like fever, headache, muscle aches, muscle pain, joint pains, reddening of the eyes, and skin rash. So if a patient presents to you like this, remember that when we are looking at our screening tool later on, this patient already has more than 3 symptoms. If they have 3 symptoms, plus that fever or history of fever, that is the patient we are looking for. So you remember these symptoms when you're looking through the screening tool. We can be able to utilize this very effectively to see which patient are we picking exactly using the screening tool. And of course, in the intermediate stage, we are saying here that those symptoms of the first stage plus now GIT symptoms, the wet symptoms, diarrhea, abdominal pain, vomiting, dysphagia, and then also now in the advanced stage, that's where we see saying that probably 30% of them may present with the bleeding from the os, mental confusion, rapid breathing, convulsions, and loss of consciousness. So most of these patients may not be presenting to you with all these symptoms. It's just to us to be very critical and scrutinize and see that they really meet the case definition that has been jointly agreed through by different experts. Yeah. So, and then also the staging of the infection, we realize that from the incubation period that lasts for about 21 days, not all of them will take all that period. Some people will just after day 1 to day 2 have their symptoms coming up. And we are saying the average number of symptoms is between 7 to 10 days for majority of the cases that have been seen. And this can be changing over time. You can have that 7 to 10 days at the start of the period. Then later on, as you improve your screening tool and all that, then you find that these days are reducing. You may find that you actually can be able to pick up, and the cases you find are between much earlier. And so from the time they now develop symptoms, we call that day 0. And so from day 0 to day 7, that is an early stage of the infection, and doubling it to day 14 is the spike stage, and then patient recovers later on. So that's generally the natural history of that of the illness. And our role, therefore, of treatment is to see that we manage the symptoms of the patient and make sure the patient goes through the infection. So lab diagnosis, our main, our gold standard, of course, is the PCR, where samples are picked up from the suspect that has been evaluated by a lower facility, and the alert management has been contacted. So this alert management comes in and reevaluate and picks up the sample. Remember, these samples are strictly picked by trained staff, and in this case of this outbreak, it is the KCCA team that will be coming up to pick. Our role is just to signal the KCCA team whenever we find a case has met a case definition for a suspect. But of course, we have a rapid test, either the antigen or the antibody, and of course that is subject to an explanation. If you do an antibody test, you are typically detecting even including the old infection. Someone had an infection and he has recovered maybe last week, and then you do an antibody test, you can be able to turn out positive. It doesn't mean that you're infectious. So for us to be sure of whether someone is infectious or not infectious, we typically just go for our PCR test, which is quite readily available, and the team from KCCA is quickly